Welcome to this comprehensive presentation on the pharmacological management of thyroid disorders, focusing on hypothyroidism. We will explore the physiological processes governing thyroid function, the pathophysiology of hypothyroid states, and the clinical pharmacology of replacement therapies, LT4 and LT3. We will cover genomic mechanisms, pharmacokinetic profiles, drug interactions, management in special populations, and apply these concepts through clinical case studies. Understanding thyroid pharmacology begins with the hypothalamic-Pituitary-Thyroid, or HPT, axis. This is the body's command system for controlling metabolism. The hypothalamus releases thyrotropin-releasing hormone, also called TRH. Thyrotropin-releasing hormone stimulates the pituitary gland to release thyroid-stimulating hormone, or TSH. Thyroid-stimulating hormone then signals the thyroid gland to produce the hormones thyroxine, known as T4, and triiodothyronine, known as T3. The thyroid synthesizes hormones through a series of carefully regulated steps. Iodide is actively transported into thyroid cells. It is then oxidized and attached to tyrosine residues within thyroglobulin. These iodinated molecules combine to form T3 and T4. Once released into the bloodstream, most hormone circulates bound to plasma proteins. T4 acts mainly as a prohormone and is converted in tissues into the more active hormone, T3. Hypothyroidism develops when thyroid hormone production is inadequate. The most common causes include autoimmune thyroiditis, thyroid surgery, radioactive iodine treatment, and iodine deficiency. Reduced thyroid hormone levels slow metabolic activity throughout the body. Patients often experience fatigue, weight gain, cold intolerance, constipation, dry skin, hair loss, and slowed thinking. In severe cases, untreated hypothyroidism may progress to myxedema coma, a rare but life-threatening emergency. Thyroid hormone replacement is the cornerstone of treatment. Levothyroxine, or LT4, is the preferred therapy for most patients. It is a synthetic form of T4 and provides stable hormone replacement. After absorption, it is converted into active T3 within peripheral tissues. Levothyroxine has a long half-life of about 7 days, allowing convenient once-daily dosing and steady hormone levels. Liothyronine, or LT3, is the synthetic form of active T3. It acts more rapidly than levothyroxine because it does not require conversion. However, it has a much shorter half-life and produces greater fluctuations in hormone levels. These characteristics increase the risk of palpitations, arrhythmias, and other cardiovascular effects. For this reason, levothyroxine remains the standard treatment for routine hypothyroidism, while liothyronine is reserved for selected situations. Drug interactions are clinically important. Iron supplements, calcium products, antacids, and some cholesterol-lowering agents can reduce levothyroxine absorption. Patients are usually advised to take levothyroxine on an empty stomach and separate it from interacting medications. Therapeutic monitoring relies primarily on serum thyroid-stimulating hormone levels, with free T4 measurements used when additional assessment is needed. Special populations require individualized therapy. During pregnancy, thyroid hormone requirements often increase, making close monitoring essential. Elderly patients usually require lower starting doses because of increased sensitivity to cardiovascular effects. In myxedema coma, rapid treatment with intravenous thyroid hormone and supportive care is critical. Understanding these principles helps ensure safe, effective, and patient-centered management of hypothyroidism. The thyroid gland may be small, but it plays a huge role in keeping the body running smoothly. It helps regulate metabolism, energy production, body temperature, growth, and many other essential functions. The activity of the thyroid is controlled by a sophisticated communication network known as the Hypothalamic-Pituitary-Thyroid, or HPT, axis. Everything begins in the hypothalamus, a small but powerful region of the brain. The hypothalamus constantly monitors the body's needs and hormone levels. When thyroid hormone levels begin to fall, it releases thyrotropin-releasing hormone, or TRH. Think of thyrotropin-releasing hormone as the first signal in a chain of communication that activates the thyroid gland. Thyrotropin-releasing hormone then travels a short distance to the anterior pituitary gland, often called the master gland. In response to thyrotropin-releasing hormone stimulation, the anterior pituitary releases thyroid-stimulating hormone, or TSH, into the bloodstream. Thyroid-stimulating hormone serves as the primary messenger that tells the thyroid gland how hard it should work. Once thyroid-stimulating hormone reaches the thyroid gland in the neck, it stimulates the synthesis and release of the thyroid hormones thyroxine, or T4, and triiodothyronine, or T3. The thyroid produces much larger amounts of T4, while T3 is the more biologically active hormone. Many tissues throughout the body convert T4 into T3 to meet their metabolic needs. These hormones travel through the bloodstream and affect nearly every organ system. They increase oxygen consumption, support normal growth and development, enhance energy production, and help maintain normal heart, brain, and muscle function. When thyroid hormone levels are adequate, cells throughout the body function efficiently and maintain metabolic balance. An important feature of the hypothalamic-pituitary-thyroid axis is the negative feedback loop. As circulating levels of free T4 and free T3 rise, they signal both the hypothalamus and the pituitary gland to reduce hormone production. The hypothalamus decreases thyrotropin-releasing hormone secretion, while the pituitary decreases thyroid-stimulating hormone release. This feedback mechanism prevents excessive thyroid hormone production and helps maintain stable hormone concentrations. When thyroid hormone levels drop, the opposite occurs. The hypothalamus releases more thyrotropin-releasing hormone, the pituitary secretes more thyroid-stimulating hormone, and the thyroid is stimulated to produce additional T4 and T3. This continuous adjustment allows the body to respond rapidly to changing metabolic demands. The hypothalamic-pituitary-thyroid axis functions like a highly efficient thermostat. When hormone levels are too low, the system turns thyroid activity up. When hormone levels are too high, the system turns thyroid activity down. This precise regulation ensures that metabolism remains balanced and that the body's organs receive the hormonal support they need to function optimally every day. The production of thyroid hormones begins with a fascinating process called iodide trapping. Since iodine is an essential building block of thyroid hormones, the thyroid gland must efficiently collect it from the bloodstream. To accomplish this, specialized thyroid follicular cells use a transport protein known as the sodium iodide symporter, or NIS. Think of sodium iodide symporter as a highly efficient pump. It actively pulls iodide from the blood into thyroid cells, even when blood iodine levels are relatively low. This process requires energy and allows the thyroid gland to concentrate iodide at levels many times higher than those found in the circulation. Without this critical first step, thyroid hormone synthesis cannot occur. Once iodide enters the follicular cells, the thyroid begins preparing another important component known as thyroglobulin. Thyroglobulin, often abbreviated as Tg, is a large glycoprotein synthesized within the follicular cells. It contains numerous tyrosine amino acid residues that will later serve as attachment sites for iodine. You can think of thyroglobulin as a molecular framework or construction platform. It provides the structure on which thyroid hormones will eventually be assembled. The follicular cells manufacture thyroglobulin in the rough endoplasmic reticulum and process it through the Golgi apparatus before preparing it for release. After synthesis, thyroglobulin is packaged into secretory vesicles and transported toward the apical surface of the follicular cells. The protein is then released by exocytosis into the center of the thyroid follicle, a space known as the follicular lumen. This lumen contains a gel-like substance called colloid. The colloid acts as a storage reservoir and an extracellular workspace for thyroid hormone production. Once thyroglobulin enters the colloid, it forms the scaffold on which future hormone synthesis will take place. The colloid is unique because the thyroid gland stores large amounts of hormone precursor outside the cells. This feature allows the thyroid to maintain a reserve supply of material that can support hormone production for weeks or even months if iodine intake temporarily decreases. At this stage, the essential ingredients are now in place. Iodide has been actively trapped from the bloodstream, and thyroglobulin has been synthesized and deposited into the colloid. The thyroid gland has effectively prepared the raw materials and the structural framework needed for hormone formation. These early steps may seem simple, but they are absolutely vital. Any disruption in iodide transport, thyroglobulin synthesis, or colloid formation can impair thyroid hormone production and lead to thyroid dysfunction. Together, iodide trapping and thyroglobulin production form the foundation upon which the entire process of thyroid hormone synthesis depends. Once iodide has been trapped by the thyroid gland and thyroglobulin has been stored in the colloid, the next phase of thyroid hormone synthesis begins. This stage involves a series of highly coordinated chemical reactions that ultimately produce the thyroid hormones T3 and T4. At the center of these reactions is an essential enzyme called thyroid peroxidase, commonly known as TPO. Think of thyroid peroxidase as the chief catalyst of thyroid hormone production. Without it, several critical steps in hormone synthesis would come to a halt. The first step is oxidation. Although iodide has been successfully transported into the thyroid gland, it is not yet in a form that can participate in hormone synthesis. Thyroid peroxidase converts iodide into active iodine through an oxidation reaction. This transformation is crucial because only active iodine can bind to the tyrosine residues found on thyroglobulin. Next comes organification. During this process, thyroid peroxidase attaches active iodine to specific tyrosine molecules located on the thyroglobulin scaffold within the colloid. When one iodine atom attaches to a tyrosine residue, it forms monoiodotyrosine, or MIT. When two iodine atoms attach, the product is diiodotyrosine, or DIT. These iodinated tyrosines are the immediate building blocks of thyroid hormones. At this stage, the thyroid has not yet produced T3 or T4, but the necessary components are now in place. The colloid essentially becomes a biochemical assembly line where hormone precursors are carefully prepared. The final step is coupling. Again, thyroid peroxidase plays a central role. The enzyme joins specific iodinated tyrosines together while they remain attached to thyroglobulin. When one monoiodotyrosine molecule combines with one diiodotyrosine molecule, triiodothyronine, or T3, is formed. When two diiodotyrosine molecules combine, thyroxine, or T4, is produced. Most of the hormone synthesized by the thyroid gland is T4, while smaller amounts of T3 are generated directly. Although T3 is the more biologically active hormone, much of the body's T3 is later produced by conversion of T4 in peripheral tissues such as the liver, kidneys, and muscles. These reactions occur with remarkable efficiency. The thyroid gland continuously oxidizes iodide, incorporates iodine into thyroglobulin, and couples iodinated residues to maintain a steady supply of thyroid hormones. This process ensures that the body has the hormones needed to regulate metabolism, growth, energy production, and normal organ function. Understanding oxidation, organification, and coupling is clinically important because several thyroid disorders and medications target these exact steps. Any disruption in thyroid peroxidase activity can significantly reduce thyroid hormone production and alter the body's metabolic balance. These carefully coordinated reactions represent the biochemical heart of thyroid hormone synthesis. Although the thyroid gland releases both T4 and T3, most of the hormone produced is T4. Interestingly, T4 is not the hormone that performs most thyroid actions within cells. Instead, it serves primarily as a pro-hormone, meaning it must be converted into the more active hormone, T3, before it can exert its full biological effects. This conversion occurs in tissues throughout the body and is carried out by specialized enzymes known as deiodinases. These enzymes carefully regulate how much active thyroid hormone is available to different organs. In many ways, deiodinases act like local control systems that fine-tune thyroid hormone activity according to each tissue's needs. One of the most important enzymes is type 1 deiodinase, or D1. This enzyme is found mainly in the liver and kidneys. D1 converts circulating T4 into active T3 and contributes significantly to the amount of T3 present in the bloodstream. Because of this role, D1 helps maintain normal systemic thyroid hormone levels and supports metabolism throughout the body. Another key enzyme is type 2 deiodinase, or D2. This enzyme is highly expressed in the central nervous system, pituitary gland, and several other tissues. Unlike D1, D2 focuses less on producing circulating T3 and more on generating T3 directly within cells. This local production ensures that critical tissues, especially the brain, always have an adequate supply of active thyroid hormone, even when blood hormone levels fluctuate. D2 also plays an important role in the pituitary gland. By generating local T3, it helps the pituitary accurately sense thyroid hormone status and regulate thyroid-stimulating hormone, or TSH, secretion. This mechanism contributes to the precise control of the hypothalamic-Pituitary-Thyroid axis. Not all deiodinases activate thyroid hormones. Type 3 deiodinase, or D3, performs the opposite function. D3 protects tissues from excessive thyroid hormone activity by inactivating hormones when necessary. It converts T4 into reverse T3, often called RT3. Reverse T3 closely resembles active T3 in structure but has little or no biological activity. By producing reverse T3, D3 effectively reduces thyroid hormone action within tissues. This mechanism becomes particularly important during illness, fetal development, and certain physiological states where the body may need to conserve energy or limit thyroid hormone effects. Together, D1, D2, and D3 create a sophisticated regulatory network. D1 supplies much of the circulating T3. D2 ensures adequate local hormone activity in vital organs such as the brain and pituitary. D3 prevents excessive stimulation by converting hormones into inactive forms. This balance between activation and inactivation allows the body to precisely control thyroid hormone action. Rather than relying solely on the thyroid gland, tissues themselves participate in regulating hormone activity. This elegant system ensures that each organ receives the right amount of thyroid hormone at the right time to maintain normal growth, metabolism, and physiological function. Hypothyroidism is a common endocrine disorder that occurs when the thyroid gland fails to produce enough thyroid hormones to meet the body's needs. Because thyroid hormones regulate metabolism in nearly every organ, a deficiency can affect multiple body systems. The result is a clinical syndrome characterized by a generalized slowing of physiological processes. In simple terms, hypothyroidism causes the body's metabolic engine to run at a slower pace. As thyroid hormone levels fall, cells produce less energy and perform their functions less efficiently. This gradual decline often develops over months or even years, making symptoms easy to overlook in the early stages. One of the hallmark features of hypothyroidism is metabolic slowing. Patients frequently experience persistent fatigue and reduced energy levels. Everyday activities may feel more exhausting than usual. Many individuals report lethargy, decreased motivation, and a general sense of sluggishness. Weight gain is also common, partly because the body's basal metabolic rate declines. Even without major changes in diet, patients may notice gradual increases in body weight. The cardiovascular system is also affected. Thyroid hormones normally help maintain heart rate and cardiac output. When hormone levels are low, the heart tends to beat more slowly, a condition known as bradycardia. As a result, some patients experience reduced exercise tolerance and tire more easily during physical activity. Hypothyroidism also produces several characteristic physical manifestations. Cold intolerance is particularly common. Patients often feel unusually cold even when others are comfortable. This occurs because reduced metabolism decreases heat production throughout the body. Changes in the skin are another important feature. The skin often becomes dry, rough, and cool to the touch. Hair may become brittle and thin, while nails may grow more slowly. These changes reflect the reduced metabolic activity of skin and other tissues. The gastrointestinal system slows as well. Decreased intestinal motility commonly leads to constipation. Patients may notice less frequent bowel movements and increased difficulty passing stool. This symptom often improves once thyroid hormone replacement therapy is initiated. One of the most distinctive features of severe hypothyroidism is myxedema. Unlike ordinary swelling caused by excess fluid, myxedema results from the accumulation of hydrophilic mucopolysaccharides within the skin and subcutaneous tissues. These substances attract and retain water, producing a characteristic non-pitting edema. The face may appear puffy, the eyelids swollen, and the skin thickened. Hypothyroidism can range from mild, subclinical disease to severe hormone deficiency. Regardless of severity, the underlying problem remains the same: inadequate thyroid hormone activity. Recognizing the symptoms of metabolic slowing, physical changes, and myxedema is essential for early diagnosis and treatment. With appropriate thyroid hormone replacement, most patients experience significant improvement and a return to normal metabolic function. Primary hypothyroidism is the most common form of hypothyroidism and accounts for more than 95% of all cases. In this condition, The problem originates within the thyroid gland itself. The gland becomes unable to produce sufficient amounts of thyroid hormones, even though the hypothalamus and pituitary gland continue sending signals to stimulate hormone production. Among the many causes of primary hypothyroidism, Hashimoto's thyroiditis is by far the most common in regions where iodine intake is adequate. Hashimoto's thyroiditis is a chronic autoimmune disorder in which the body's immune system mistakenly attacks its own thyroid tissue. Normally, the immune system protects the body from infections and harmful foreign substances. In Hashimoto's disease, however, immune cells lose tolerance to thyroid proteins and begin targeting the thyroid gland. Over time, this abnormal immune response leads to progressive destruction of thyroid follicles, the microscopic structures responsible for synthesizing and storing thyroid hormones. The disease process is primarily driven by cell-mediated immunity. Activated T lymphocytes infiltrate the thyroid gland and trigger inflammation. These immune cells directly damage thyroid follicular cells and recruit additional inflammatory cells to the gland. As the destruction continues, healthy thyroid tissue is gradually replaced by fibrous and dysfunctional tissue. In the early stages, the thyroid may still produce enough hormone to meet the body's needs. Many patients remain asymptomatic for years. As more follicles are destroyed, however, the gland's ability to synthesize thyroxine, or T4, and triiodothyronine, or T3, progressively declines. Eventually, thyroid hormone levels fall below normal, resulting in overt hypothyroidism. The pituitary gland attempts to compensate for this decline by increasing the secretion of thyroid-stimulating hormone, or TSH. Elevated thyroid-stimulating hormone levels often represent one of the earliest laboratory findings in Hashimoto's thyroiditis. As thyroid function continues to deteriorate, symptoms of hypothyroidism gradually emerge, including fatigue, weight gain, cold intolerance, constipation, and dry skin. A key feature of Hashimoto's thyroiditis is the presence of circulating autoantibodies directed against thyroid components. Two important biomarkers are anti-thyroid peroxidase antibodies, commonly called anti-TPO antibodies, and anti-thyroglobulin antibodies, known as anti-TG antibodies. Anti-thyroid peroxidase antibodies are the most sensitive and commonly detected marker. They target thyroid peroxidase, the enzyme responsible for several critical steps in thyroid hormone synthesis. Anti-thyroglobulin antibodies target thyroglobulin, the protein scaffold used to produce thyroid hormones. High levels of these antibodies strongly support the diagnosis of autoimmune thyroid disease. Hashimoto's thyroiditis illustrates how a dysregulated immune system can gradually impair endocrine function. Through persistent autoimmune destruction of thyroid follicles, the gland slowly loses its ability to produce hormones. Recognizing the role of autoimmune mechanisms and antibody biomarkers is essential for understanding the pathogenesis, diagnosis, and long-term management of primary hypothyroidism. Although Hashimoto's thyroiditis is the most common cause of primary hypothyroidism in many developed countries, several other conditions can also impair thyroid hormone production. These causes ultimately lead to the same outcome: an underactive thyroid gland that cannot meet the body's hormonal demands. Globally, iodine deficiency remains the most common cause of primary hypothyroidism. Iodine is an essential component of both T3 and T4. Without an adequate iodine supply, the thyroid gland cannot synthesize sufficient amounts of these hormones. As hormone production declines, The pituitary gland responds by releasing more thyroid-stimulating hormone, or TSH, in an attempt to stimulate the thyroid. This persistent thyroid-stimulating hormone stimulation causes the thyroid gland to enlarge, resulting in a condition known as a goiter. When iodine deficiency affects large populations within a geographic region, the condition is referred to as endemic goiter. Although iodized salt programs have reduced its prevalence in many countries, iodine deficiency remains an important public health problem in some parts of the world. Primary hypothyroidism can also result from medical treatment, a situation known as iatrogenic hypothyroidism. One common cause is surgical removal of the thyroid gland. Patients may undergo partial or complete thyroidectomy for thyroid cancer, large goiters, or hyperthyroidism. If sufficient thyroid tissue is removed, hormone production falls and lifelong thyroid hormone replacement may become necessary. Another important iatrogenic cause is radioactive iodine, often abbreviated as RAI, therapy. Radioactive iodine is commonly used to treat hyperthyroidism and certain thyroid cancers. Because thyroid cells actively absorb iodine, radioactive iodine selectively destroys thyroid tissue. While this treatment is highly effective, it may leave patients with insufficient functioning thyroid tissue, eventually leading to hypothyroidism. Certain medications can also interfere with thyroid function and trigger hypothyroidism. One notable example is amiodarone, a widely used antiarrhythmic drug. Amiodarone contains large amounts of iodine and can disrupt normal thyroid hormone synthesis through a mechanism known as the Wolff-Chaikoff effect. The Wolff-Chaikoff effect occurs when excessive iodine temporarily suppresses thyroid hormone production. In some individuals, especially those with underlying thyroid disease, the gland fails to escape from this inhibitory effect, resulting in persistent hypothyroidism. Lithium is another medication associated with thyroid dysfunction. Commonly used in the treatment of bipolar disorder, lithium interferes with the release of thyroid hormones from follicular cells. Even when hormones are successfully synthesized, lithium can reduce their secretion into the bloodstream. Over time, this may lead to clinically significant hypothyroidism. These diverse causes highlight the importance of thyroid hormone synthesis and release. Whether due to nutritional deficiency, medical intervention, or medication effects, disruption of normal thyroid function can produce similar clinical manifestations. Understanding these causes helps clinicians identify risk factors, monitor vulnerable patients, and provide timely treatment to restore normal thyroid hormone levels and metabolic balance. Most cases of hypothyroidism result from problems within the thyroid gland itself, but thyroid hormone deficiency can also arise from disorders affecting higher levels of the hypothalamic-Pituitary-Thyroid, or HPT, axis. These less common forms include secondary hypothyroidism, tertiary hypothyroidism, and subclinical hypothyroidism. Secondary hypothyroidism occurs when the pituitary gland fails to produce adequate amounts of thyroid-stimulating hormone, or TSH. Remember, thyroid-stimulating hormone is the hormone responsible for signaling the thyroid gland to produce and release T3 and T4. If the pituitary cannot generate enough thyroid-stimulating hormone, the thyroid receives insufficient stimulation and hormone production declines. This condition is sometimes referred to as central hypothyroidism because the problem originates in the central regulatory system rather than the thyroid gland itself. Common causes include pituitary tumors, pituitary surgery, radiation therapy, traumatic brain injury, and disorders that damage pituitary tissue. Because thyroid-stimulating hormone levels are low or inappropriately normal, diagnosis can be more challenging than in primary hypothyroidism. Tertiary hypothyroidism is even less common. In this form, the defect originates in the hypothalamus. Under normal circumstances, the hypothalamus secretes thyrotropin-releasing hormone, or TRH, which stimulates the pituitary to release thyroid-stimulating hormone. When hypothalamic function is impaired, thyrotropin-releasing hormone production decreases. Without sufficient thyrotropin-releasing hormone, the pituitary releases less thyroid-stimulating hormone, and the thyroid gland subsequently produces less T3 and T4. In essence, the hormonal signal is disrupted at the very beginning of the hypothalamic-pituitary-thyroid axis. Causes may include hypothalamic tumors, infiltrative diseases, radiation injury, or other conditions affecting hypothalamic function. Both secondary and tertiary hypothyroidism result in inadequate thyroid hormone production, but the underlying problem lies outside the thyroid gland. This distinction is important because laboratory findings differ from those seen in primary hypothyroidism. Instead of elevated thyroid-stimulating hormone levels, patients often have low or inappropriately normal thyroid-stimulating hormone despite reduced thyroid hormone concentrations. Another important category is subclinical hypothyroidism. This condition represents an early stage of thyroid dysfunction. Patients typically have elevated thyroid-stimulating hormone levels but normal free thyroxine, or free T4, concentrations. The increased thyroid-stimulating hormone reflects the pituitary's effort to compensate for declining thyroid function and maintain normal circulating hormone levels. Many individuals with subclinical hypothyroidism have few symptoms or no symptoms at all. Others may experience mild fatigue, weight gain, or cold intolerance. Because free T4 remains within the normal range, the body's tissues continue receiving adequate hormone supply despite increased pituitary stimulation. Subclinical hypothyroidism is clinically important because some patients eventually progress to overt hypothyroidism, particularly those with positive thyroid autoantibodies. Regular monitoring of thyroid function tests helps identify individuals who may require future treatment. Understanding secondary, tertiary, and subclinical hypothyroidism highlights the complexity of thyroid regulation. Disorders can occur at the thyroid gland, pituitary gland, or hypothalamus, and each level produces distinct hormonal patterns that guide diagnosis and management. Myxedema coma represents the most severe and dangerous form of hypothyroidism. Although the name suggests that every patient is unconscious, this is not always the case. The term refers to a state of profound thyroid hormone deficiency in which the body's normal compensatory mechanisms fail. It is a rare medical emergency and carries a high risk of mortality if not recognized and treated promptly. In most cases, myxedema coma develops in individuals with long-standing, untreated, or inadequately treated hypothyroidism. Over time, the body's metabolism slows dramatically. Eventually, a stressful event may overwhelm the body's limited reserves and trigger rapid clinical deterioration. Several factors can precipitate myxedema coma. Infection is one of the most common triggers. Conditions such as pneumonia or urinary tract infections can place significant stress on an already compromised system. Trauma, surgery, certain medications, and exposure to cold environments can also precipitate this life-threatening condition. Because patients with severe hypothyroidism have impaired thermoregulation and reduced physiological reserve, they often struggle to respond effectively to these stressors. One of the hallmark features of myxedema coma is altered mental status. Patients may initially appear confused, forgetful, or unusually lethargic. As the condition progresses, mental function can deteriorate further, leading to profound drowsiness, stupor, and eventually coma. This progressive decline reflects the critical role thyroid hormones play in maintaining normal brain function. Hypothermia is another characteristic finding. The body's ability to generate heat becomes severely impaired due to the profound reduction in metabolic activity. Body temperature may fall significantly below normal, sometimes reaching dangerously low levels. In severe cases, hypothermia itself can worsen cardiovascular and neurological dysfunction. The cardiovascular system is also profoundly affected. Bradycardia, or an abnormally slow heart rate, occurs because thyroid hormones normally help maintain cardiac output and heart rate. As hormone levels decline, the heart beats more slowly and less efficiently. This can contribute to reduced tissue perfusion and worsening organ dysfunction. Hypotension, or low blood pressure, is another common feature. Decreased cardiac output, impaired vascular responsiveness, and reduced metabolic demand all contribute to circulatory instability. If untreated, hypotension can progress to shock and multiple organ failure. Additional findings may include respiratory depression, decreased oxygenation, hyponatremia, hypoglycemia, and generalized non-pitting edema associated with myxedema. These abnormalities further complicate the clinical picture and increase the risk of mortality. Myxedema coma is a true endocrine emergency. Early recognition is critical because symptoms can initially appear subtle. Prompt treatment with intravenous thyroid hormone replacement, supportive care, management of underlying triggers, and close monitoring in an intensive care setting can be life-saving. Understanding the triggers and clinical features of myxedema coma is essential for recognizing this rare but potentially fatal complication of severe hypothyroidism. Levothyroxine, also known as LT4, is a synthetic form of thyroxine, the main hormone naturally produced by the thyroid gland. It belongs to the class of thyroid hormone replacement medications and is widely used to treat hypothyroidism, a condition in which the thyroid does not produce enough hormones. Think of levothyroxine as a replacement for the body's missing thyroid hormone. Its structure is virtually identical to the naturally occurring thyroxine hormone, allowing it to perform the same physiological role once it enters the bloodstream. Interestingly, levothyroxine itself is considered a pro-hormone. This means that much of its biological activity depends on being converted into the more active hormone, triiodothyronine, or T3. This conversion takes place in various tissues throughout the body, including the liver, kidneys, brain, and muscles. The conversion process is carried out by specialized enzymes called deiodinases. Two key enzymes, type 1 deiodinase, D1, and type 2 deiodinase, D2, remove an iodine atom from thyroxine, transforming it into active triiodothyronine. Once formed, triiodothyronine enters cells and binds to thyroid hormone receptors within the nucleus. This receptor binding influences the expression of numerous genes involved in metabolism, growth, development, and energy production. As a result, thyroid hormone helps regulate heart rate, body temperature, oxygen consumption, and the body's overall metabolic activity. Because levothyroxine relies on the body's own deiodinase enzymes for activation, its effectiveness depends on normal peripheral conversion mechanisms. In most patients, this process occurs efficiently, making levothyroxine the standard first-line therapy for thyroid hormone replacement worldwide. Here's an expanded version written in a conversational style with short, video-friendly sentences. To understand how levothyroxine works at the genetic level, we need to follow what happens after thyroxine is converted into the active hormone, triiodothyronine. Once triiodothyronine is produced inside tissues, it travels into the cell nucleus. Think of the nucleus as the cell's control center, where important genetic instructions are stored. Inside the nucleus, triiodothyronine binds to specialized proteins called thyroid hormone receptors. These receptors exist mainly in two forms, TR-alpha and TR-beta. They act like molecular switches that control how specific genes are turned on or off. But triiodothyronine does not work alone. After binding to its receptor, the thyroid hormone receptor joins with another protein called the retinoid X receptor, or RXR. Together, they form a partnership known as a heterodimer. This receptor pair is much more powerful than either receptor alone. The triiodothyronine TRXR complex then searches for specific regions on DNA called thyroid hormone response elements, or TRES. These DNA sequences function like docking sites for thyroid hormone signaling. When the complex attaches to a thyroid hormone response element, it influences gene transcription. In simple terms, it tells the cell which genes should become more active and which should become less active. As a result, the cell begins producing proteins that regulate metabolism, growth, development, and energy production. This genomic effect explains why levothyroxine does not work instantly. Changes in gene expression take time. New proteins must be produced before the full physiological effects become noticeable. Over time, these genetic changes increase oxygen consumption, support normal growth and tissue repair, regulate body temperature, and help maintain healthy cardiovascular and nervous system function. In essence, levothyroxine works by providing thyroxine, which is converted into triiodothyronine. Triiodothyronine then enters the nucleus, binds to TR-alpha and TR-beta receptors, forms a heterodimer with RXR, and attaches to thyroid hormone response elements on DNA. This process alters gene transcription and ultimately drives many of the body's essential metabolic functions. When discussing levothyroxine therapy, absorption is one of the most important factors affecting treatment success. Even when patients take the correct dose, the body may not absorb all of the medication. This can lead to fluctuating thyroid hormone levels and difficulty achieving treatment goals. After oral administration, levothyroxine has a bioavailability of approximately 60 to 80%. In other words, only a portion of the swallowed dose actually reaches the bloodstream. Several everyday factors can interfere with this absorption process. One common challenge is dietary fiber. High-fiber foods can bind to levothyroxine within the digestive tract and reduce the amount available for absorption. This is why timing of medication and meals can be important. Coffee is another well-known culprit. Drinking coffee too soon after taking levothyroxine can significantly reduce absorption. The medication may pass through the gastrointestinal tract before it has enough time to be fully absorbed. Gastric acidity also plays a critical role. Levothyroxine tablets must dissolve properly in the stomach before they can be absorbed in the small intestine. Conditions that reduce stomach acid can interfere with this process. This is particularly relevant for patients taking proton pump inhibitors, commonly known as PPIs. These medications decrease gastric acid production and may lower the effectiveness of levothyroxine absorption in some individuals. Another major absorption challenge involves a process called chelation. Certain minerals contain positively charged metal ions known as polyvalent cations. When these minerals come into contact with levothyroxine in the digestive tract, they can bind tightly to the drug. Once bound, the resulting complex becomes difficult for the intestine to absorb. Iron supplements are a common example. Calcium supplements can have a similar effect. Antacids containing aluminum may also reduce levothyroxine absorption through the same mechanism. As a result, patients are often advised to separate levothyroxine from these products by several hours to minimize interactions. The key takeaway is that successful levothyroxine therapy depends not only on the prescribed dose but also on proper absorption. Factors such as dietary fiber, coffee, reduced stomach acidity, and mineral supplements can all decrease the amount of medication reaching the bloodstream. Understanding these absorption challenges helps explain why consistent medication timing and awareness of drug-food interactions are essential for achieving stable thyroid hormone levels. Here's an enriched, video-friendly version written with short sentences and a conversational educational tone. Once levothyroxine is absorbed into the bloodstream, the next step is distribution throughout the body. This is where the drug is transported to various tissues and organs where it can eventually exert its effects. Interestingly, very little levothyroxine circulates freely in the blood. More than 99% of circulating thyroxine is bound to transport proteins. The most important of these proteins is thyroxine-binding globulin, commonly known as TBG. Think of thyroxine-binding globulin as a transport vehicle. It carries thyroid hormone safely through the bloodstream and acts as a reservoir that helps maintain stable hormone levels over time. Only a tiny fraction of thyroxine remains unbound, or free. This free hormone is the biologically active portion that can enter cells and participate in metabolic processes. The high degree of protein binding is one reason levothyroxine has a relatively long duration of action. The bound hormone serves as a storage pool that can gradually release thyroxine as needed. After distribution, levothyroxine undergoes metabolism. The primary metabolic pathway is called sequential iodination. This process involves the stepwise removal of iodine atoms from the thyroid hormone molecule by specialized enzymes known as deiodinases. The most important conversion is the transformation of thyroxine into triiodothyronine, the more biologically active thyroid hormone. Triiodothyronine is responsible for most of the hormone's effects on metabolism, growth, energy production, and cellular function. Further deiodination can also produce inactive metabolites, helping regulate overall thyroid hormone activity within different tissues. Once metabolism is complete, the body must eliminate the hormone and its metabolites. The liver plays a central role in this clearance process. Within the liver, thyroid hormones undergo conjugation reactions, particularly glucuronidation. During this process, chemical groups are attached to the hormone molecules, making them more water-soluble and easier to eliminate. These conjugated metabolites are then secreted into bile. Bile carries the metabolites into the intestinal tract, where they are eventually excreted from the body. This combination of extensive protein binding, gradual metabolism, and efficient hepatic clearance contributes to the predictable pharmacokinetic profile of levothyroxine. In simple terms, levothyroxine travels through the bloodstream largely bound to thyroxine-binding globulin, undergoes sequential iodination to generate active and inactive metabolites, and is ultimately cleared through liver conjugation and biliary excretion. These processes help maintain stable thyroid hormone levels and support the long-lasting therapeutic effects of levothyroxine. One of the most important pharmacokinetic features of levothyroxine is its long half-life. This characteristic helps explain why the medication is usually taken only once a day and why dose adjustments require patience. In healthy adults, levothyroxine has an average half-life of approximately 7 days. The half-life refers to the time required for the amount of drug in the body to decrease by half. This means that even after a single dose, levothyroxine remains in the body for an extended period. The hormone is released gradually from its protein-bound stores and cleared slowly over time. This long duration of action provides a relatively stable supply of thyroid hormone between doses. It also helps protect against large fluctuations in hormone levels when doses are taken consistently. However, the half-life is not always the same for every patient. In individuals with hypothyroidism, metabolic processes are generally slower. As a result, levothyroxine is cleared from the body more slowly than usual. In these patients, the half-life can extend to approximately 9 to 10 days. This prolonged persistence means that thyroid hormone remains in circulation for a longer period before being eliminated. Understanding this concept is important when evaluating treatment response. Many patients expect to feel better immediately after starting therapy or after a dose increase. However, levothyroxine does not produce its full effects overnight. Because the drug accumulates gradually and is eliminated slowly, it takes time for blood concentrations to stabilize. This brings us to the concept of steady state. A steady state occurs when the amount of medication entering the body equals the amount being removed. At this point, hormone levels become relatively stable from day to day. For levothyroxine, reaching a new steady state after a dose adjustment typically requires 4 to 6 weeks. This delay is directly related to the drug's long half-life. Since each dose remains in the body for many days, multiple dosing cycles are needed before the full impact of a dosage change becomes apparent. This is also why healthcare providers usually wait several weeks before repeating thyroid function tests after adjusting the dose. Testing too early may provide misleading results because the body has not yet reached its new equilibrium. In simple terms, levothyroxine works slowly but steadily. Its 7-day half-life, longer persistence in hypothyroid patients, and 4 to 6 week period to reach steady state are key reasons why thyroid hormone replacement requires consistency, patience, and careful monitoring. When patients begin taking levothyroxine, one of the most common questions is, how long will it take before I feel better? The answer lies in the drug's pharmacodynamics, or how the medication produces its effects within the body over time. Unlike some medications that work within hours, levothyroxine acts gradually. This is because it does more than simply enter the bloodstream. It must be distributed to tissues, converted into active triiodothyronine, enter cells, and influence gene expression before noticeable effects occur. As a result, symptom improvement is usually not immediate. Most patients begin to notice gradual changes within 1 to 2 weeks of starting treatment or after a dose adjustment. Energy levels may start to improve. Mental clarity may increase. Feelings of fatigue and sluggishness may begin to lessen. However, these early improvements represent only the beginning of the therapeutic response. The full clinical effect of levothyroxine typically requires 4 to 6 weeks to develop. During this time, hormone levels continue to stabilize, and the body's tissues gradually adapt to the restored thyroid hormone supply. This delayed response is directly related to the medication's long half-life and its genomic mechanism of action. Since levothyroxine influences the production of cellular proteins, the body needs time to complete these biological changes. For this reason, Healthcare providers generally wait several weeks before assessing the full impact of a new dose. Another important pharmacodynamic advantage of levothyroxine is its built-in buffering effect. Because the medication remains in the body for many days, hormone levels do not drop dramatically after a single missed dose. The large circulating and protein-bound stores of thyroid hormone continue to provide physiological support. This means that accidentally missing one dose is unlikely to cause an immediate return of hypothyroid symptoms in most patients. The body's hormone reservoir helps smooth out minor day-to-day variations in dosing. Of course, this protective effect has limits. Repeatedly missing doses can eventually reduce hormone levels and compromise treatment effectiveness. Nevertheless, the long half-life of levothyroxine provides a significant clinical benefit by maintaining relatively stable thyroid hormone concentrations over time. In simple terms, levothyroxine is a medication that rewards consistency and patience. Most patients notice early improvements within 1 to 2 weeks. Full therapeutic benefits emerge over 4 to 6 weeks, and the drug's long-lasting nature helps protect against the effects of an occasional missed dose. Once levothyroxine therapy has been started, the next important step is monitoring. This process is known as therapeutic drug monitoring, or TDM. The goal of monitoring is simple. We want to ensure that the patient is receiving enough thyroid hormone to restore normal function, but not so much that it causes overtreatment. For most patients with primary hypothyroidism, the most useful laboratory marker is thyroid-stimulating hormone, commonly known as TSH. Thyroid-stimulating hormone is produced by the pituitary gland and acts as the body's thyroid hormone sensor. When thyroid hormone levels are low, the pituitary releases more thyroid-stimulating hormone to stimulate the thyroid gland. When thyroid hormone levels are adequate, thyroid-stimulating hormone production decreases. Because of this feedback relationship, thyroid-stimulating hormone is considered the most sensitive marker for assessing thyroid hormone replacement in primary hypothyroidism. Even small changes in thyroid hormone levels can produce noticeable changes in thyroid-stimulating hormone concentrations. This makes thyroid-stimulating hormone a valuable tool for adjusting levothyroxine doses. In most adults receiving treatment for primary hypothyroidism, the typical target thyroid-stimulating hormone range is approximately 0.4 to 4 milli-international units per liter. When thyroid-stimulating hormone falls within this range, it generally suggests that thyroid hormone replacement is appropriate and that the body's hormonal balance has been restored. However, there is an important exception. Not all forms of hypothyroidism can be monitored using thyroid-stimulating hormone alone. In central hypothyroidism, the problem does not originate in the thyroid gland itself. Instead, it arises from dysfunction of the pituitary gland or hypothalamus. Because these structures are responsible for producing and regulating thyroid-stimulating hormone, thyroid-stimulating hormone levels may be abnormally low, normal, or otherwise misleading, even when thyroid hormone levels are inadequate. In these patients, thyroid-stimulating hormone can no longer be relied upon as an accurate indicator of treatment response. Instead, clinicians monitor free thyroxine levels. Free thyroxine represents the unbound and biologically available fraction of circulating thyroxine. Measuring free thyroxine provides a more direct assessment of thyroid hormone status in patients with central hypothyroidism. This distinction is extremely important because relying on thyroid-stimulating hormone alone in central hypothyroidism may lead to undertreatment or inappropriate dose adjustments. In summary, Thyroid-stimulating hormone remains the gold standard monitoring marker for most patients with primary hypothyroidism, with a typical target range of 0.4 to 4 milli-international units per liter. However, in central hypothyroidism, thyroid-stimulating hormone becomes unreliable, and free thyroxine should be used to guide levothyroxine therapy and assess treatment effectiveness. While levothyroxine, or LT4, is the most commonly prescribed thyroid hormone replacement, another important option is liothyronine, also known as LT3. Liothyronine belongs to the class of synthetic thyroid hormones. Unlike levothyroxine, which serves primarily as a pro-hormone, liothyronine is the active form of thyroid hormone itself. This distinction is very important. When a patient takes levothyroxine, the body must first convert T4 into triiodothyronine before most biological effects can occur. Liothyronine bypasses this step completely. Because it is already in its active form, triiodothyronine can begin working immediately after entering target tissues. Once inside cells, liothyronine travels directly to the nucleus. There, it binds to thyroid hormone receptors known as TR-alpha and TR-beta. These receptors act like genetic control switches. After binding to these receptors, triiodothyronine influences the transcription of numerous genes involved in metabolism, growth, energy production, and cellular function. In simple terms, liothyronine directly activates the genetic machinery responsible for many thyroid hormone effects throughout the body. Since no peripheral conversion is required, the response to liothyronine is often faster than the response to levothyroxine. This rapid activity can be useful in selected clinical situations where a quicker thyroid hormone effect is desired. Another important feature of liothyronine is its potency. On a microgram to microgram basis, triiodothyronine is approximately 3 to 4 times more potent than levothyroxine. This means that much smaller doses are needed to produce significant physiological effects. The reason for this greater potency lies in triiodothyronina's stronger biological activity at the cellular level. It binds thyroid hormone receptors more effectively and serves as the primary hormone responsible for regulating metabolic processes within tissues. However, greater potency also requires greater caution. Because liothyronine acts more rapidly and more powerfully, excessive dosing can lead to symptoms of thyroid hormone excess more quickly than levothyroxine. Patients may experience palpitations, nervousness, tremors, increased heart rate, or other signs of over-replacement if doses are not carefully adjusted. For this reason, liothyronine is typically used selectively and under close clinical supervision. In summary, liothyronine is a synthetic form of active triiodothyronine hormone. It does not require conversion before becoming effective, binds directly to nuclear thyroid hormone receptors, and produces its effects by regulating gene transcription. Because it is approximately 3 to 4 times more potent than levothyroxine, it can generate powerful physiological effects at relatively small doses. Liothyronine, or LT3, differs from levothyroxine in several important ways. While both are thyroid hormone medications, their pharmacokinetic and pharmacodynamic profiles are quite different. One of the most notable features of liothyronine is its rapid absorption. After oral administration, approximately 95% of the dose is absorbed from the gastrointestinal tract. This high bioavailability means that most of the medication successfully enters the bloodstream and becomes available for biological activity. Because absorption is both rapid and efficient, blood levels of triiodothyronine can rise relatively quickly after a dose is taken. This contributes to the faster onset of action often observed with liothyronine compared with levothyroxine. Once absorbed, liothyronine does not require conversion to another hormone. It is already the active form of thyroid hormone and can immediately interact with target tissues throughout the body. Inside cells, triiodothyronine enters the nucleus and binds directly to thyroid hormone receptors. This interaction influences gene transcription and rapidly affects metabolic processes. As a result, physiological effects may appear sooner than those seen with levothyroxine therapy. However, this rapid activity comes with an important limitation. Liothyronine has a relatively short half-life. The average half-life is approximately 1 day, which is significantly shorter than the 7-day half-life of levothyroxine. A shorter half-life means that the medication is removed from the body much more quickly. Blood concentrations rise rapidly after administration, but also decline more rapidly between doses. This can lead to fluctuations in circulating hormone levels throughout the day. For this reason, liothyronine usually cannot maintain stable hormone concentrations with a single daily dose. Instead, the medication is often administered multiple times per day. Common dosing schedules include twice-daily dosing, known as BID, or 3 times daily dosing, known as TID. Dividing the total daily dose helps smooth out hormone peaks and troughs and provides more consistent thyroid hormone exposure over a 24-hour period. These pharmacokinetic characteristics help explain why liothyronine is often considered a fast-acting thyroid hormone replacement. It is absorbed efficiently, acts directly without conversion, and produces relatively rapid physiological effects. At the same time, its short half-life requires more frequent dosing to maintain stable hormone levels. In summary, liothyronine is rapidly and almost completely absorbed, with a bioavailability of about 95%. Its short 1-day half-life results in quicker clearance from the body, making multiple daily doses necessary to sustain therapeutic effects and achieve consistent thyroid hormone activity throughout the day. Although liothyronine, or LT3, can provide rapid thyroid hormone activity, it also presents several important clinical challenges. These challenges are largely related to its short half-life and rapid absorption. One of the biggest concerns is the development of peaks and troughs in blood hormone levels. After a dose of liothyronine is taken, blood concentrations rise quickly. This creates a peak, where hormone levels may become significantly higher than normal physiological levels for a short period. As the drug is metabolized and cleared, hormone levels then fall relatively quickly. This creates a trough, where concentrations may drop considerably before the next dose is taken. As a result, patients may experience fluctuations in hormone exposure throughout the day rather than the stable hormone levels typically achieved with levothyroxine. These fluctuations can sometimes make symptom control more difficult. A patient may feel overstimulated shortly after taking a dose and then experience a decline in effect several hours later. This variability is one reason why liothyronine often requires careful dose scheduling. Another important challenge is the risk of toxicity associated with post-dose hormone spikes. Because liothyronine is the active thyroid hormone and acts rapidly, excessive peak concentrations can produce symptoms similar to hyperthyroidism. Patients may notice palpitations, or an uncomfortable awareness of their heartbeat. Some individuals experience feelings of nervousness or anxiety. Others may develop hand tremors, restlessness, sweating, or difficulty sleeping. These symptoms are often most noticeable shortly after dosing, when blood levels reach their highest point. The cardiovascular system is particularly sensitive to thyroid hormone. Triiodothyronine increases heart rate, enhances cardiac contractility, and raises the body's overall metabolic demand. While these effects can be beneficial when correcting hypothyroidism, excessive stimulation may become problematic. This leads to another major concern: cardiac risk. In susceptible individuals, elevated triiodothyronine levels may increase the likelihood of cardiac arrhythmias. Arrhythmias are abnormal heart rhythms that occur when the heart's electrical activity becomes disrupted. Patients with underlying heart disease, older adults, or individuals with a history of rhythm disturbances may be especially vulnerable. In these populations, rapid increases in triiodothyronine levels can place additional stress on the cardiovascular system and may increase the risk of clinically significant rhythm abnormalities. For this reason, liothyronine is typically prescribed with caution, particularly in patients with cardiovascular risk factors. In summary, the short half-life of liothyronine can lead to peaks and troughs in hormone levels throughout the day. These fluctuations may contribute to post-dose symptoms such as palpitations, anxiety, and tremors. In susceptible patients, elevated triiodothyronine concentrations can also increase the risk of cardiac arrhythmias, making careful dosing and monitoring essential. Another topic that often generates discussion in thyroid hormone replacement is combination therapy. This approach involves using both levothyroxine, or LT4, and liothyronine, or LT3, together. The idea behind combination therapy is based on normal thyroid physiology. A healthy thyroid gland naturally produces both thyroxine and triiodothyronine. Approximately 80% of the hormone released is thyroxine, while about 20% is triiodothyronine. Because of this, some clinicians and patients have wondered whether replacing both hormones might more closely mimic the body's natural hormone production. This concept forms the rationale for combination therapy. The goal is to recreate a more physiologic balance of thyroid hormones rather than relying solely on levothyroxine and the body's ability to convert thyroxine into triiodothyronine. In theory, this sounds appealing. Some patients report persistent symptoms such as fatigue, brain fog, or reduced well-being despite having normal laboratory values while taking levothyroxine alone. This has led to interest in adding small amounts of liothyronine to standard therapy. However, clinical practice is guided by scientific evidence, not theory alone. Over the years, multiple studies have evaluated whether combination therapy consistently provides better outcomes than levothyroxine monotherapy. So far, the results have been mixed. While some individuals report subjective improvement, large clinical trials have generally failed to demonstrate a clear and consistent long-term benefit across broader patient populations. Because of this, major professional organizations have adopted a cautious position. Current guidelines from the American Thyroid Association and the American Association of Clinical Endocrinologists generally do not recommend routine use of combination therapy for most patients with hypothyroidism. Levothyroxine alone remains the standard first-line treatment. One reason for this recommendation is safety. Adding liothyronine increases the risk of excessive thyroid hormone exposure. Since triiodothyronine is the active hormone and has a shorter half-life, blood levels can rise rapidly after dosing. This can result in a condition known as iatrogenic thyrotoxicosis. The term, iatrogenic, means caused by medical treatment. In this situation, thyroid hormone levels become excessively high because of over-replacement. Patients may experience palpitations, anxiety, tremors, insomnia, excessive sweating, or an increased heart rate. Long-term overexposure can also affect bone health and place additional stress on the cardiovascular system. For these reasons, combination therapy requires careful patient selection, close monitoring, and individualized decision-making. In summary, combining LT4 and LT3 aims to mimic the thyroid gland's natural hormone secretion pattern, roughly an 80-20 ratio of thyroxine to triiodothyronine. However, current guidelines generally discourage routine use because long-term benefits remain unproven, while the risk of iatrogenic thyrotoxicosis and other adverse effects remains a significant concern. One important aspect of levothyroxine therapy is the potential for drug interactions. Some medications can significantly alter thyroid hormone levels, even when the patient is taking the correct dose. A particularly important group of interacting drugs is known as hepatic enzyme inducers. These medications stimulate the liver to produce higher amounts of drug-metabolizing enzymes, especially those belonging to the cytochrome P450, or CYP450, enzyme system. Think of these enzymes as the body's chemical processing machinery. When CYP450 activity increases, the liver becomes more efficient at metabolizing and clearing certain substances from the body. In patients taking levothyroxine, this can lead to faster breakdown and elimination of thyroid hormone. As a result, circulating thyroxine levels may decline more rapidly than expected. This means that a dose that was previously adequate may no longer provide sufficient thyroid hormone replacement. Several commonly used medications can produce this effect. One example is phenobarbital, a medication historically used for seizure disorders and certain neurological conditions. Another important example is rifampin, an antibiotic frequently used in the treatment of tuberculosis and other specific infections. Phenytoin, another anticonvulsant medication, can also increase hepatic enzyme activity and accelerate thyroid hormone clearance. When patients begin taking one of these medications, thyroid hormone requirements may change. Over time, faster thyroxine clearance can lead to lower circulating thyroid hormone concentrations. If not recognized, patients may gradually develop symptoms of inadequate thyroid hormone replacement. They may experience fatigue, reduced energy, weight gain, cold intolerance, slowed thinking, or other symptoms associated with hypothyroidism. Laboratory testing may reveal rising thyroid-stimulating hormone levels, indicating that the body is sensing insufficient thyroid hormone activity. This is why ongoing monitoring is so important. When a hepatic enzyme inducer is started, discontinued, or significantly adjusted, thyroid function tests should often be reassessed to determine whether the levothyroxine dose remains appropriate. In many cases, the clinical solution is straightforward. Because the interacting medication accelerates thyroid hormone clearance, the patient may require a higher dose of levothyroxine to maintain the desired therapeutic effect. The exact adjustment varies from person to person and should be guided by laboratory monitoring and clinical response. In summary, hepatic enzyme-inducing drugs such as phenobarbital, rifampin, and phenytoin can increase CYP450 enzyme activity and accelerate the clearance of thyroid hormone. This interaction may reduce circulating thyroxine levels and increase thyroid hormone requirements. As a result, many patients will require careful monitoring and, in some cases, an increase in their levothyroxine dose to maintain adequate thyroid hormone replacement. Not all levothyroxine drug interactions involve absorption or metabolism. Some interactions occur because other medications alter the way thyroid hormone is transported in the bloodstream or affect the activity of other drugs. A key player in this process is thyroxine-binding globulin, or TBG. As we discussed earlier, more than 99% of circulating thyroid hormone is bound to transport proteins, with thyroxine-binding globulin being the most important. This protein acts as a storage and transport system for thyroid hormones in the blood. Changes in thyroxine-binding globulin levels can influence thyroid hormone balance and may alter a patient's levothyroxine requirements. One of the most common causes of increased thyroxine-binding globulin is estrogen. Estrogen stimulates the liver to produce more thyroxine-binding globulin. As thyroxine-binding globulin levels rise, more thyroid hormone becomes bound to these proteins, temporarily reducing the amount of free hormone available to tissues. This effect is particularly important during pregnancy. Pregnant patients often experience a significant increase in thyroxine-binding globulin production, which can increase their thyroid hormone requirements. A similar effect can occur in individuals taking estrogen-containing oral contraceptive pills, commonly known as OCPs. In these situations, healthcare providers may need to increase the levothyroxine dose to maintain normal thyroid hormone levels and keep thyroid-stimulating hormone within the target range. Androgens have the opposite effect. These hormones can decrease thyroxine-binding globulin production, resulting in lower circulating thyroxine-binding globulin levels. With fewer binding proteins available, a greater proportion of thyroid hormone remains unbound and biologically active. As a result, some patients may require lower doses of levothyroxine when significant androgen effects are present. Another clinically important interaction involves warfarin. Warfarin is an anticoagulant medication used to reduce the risk of harmful blood clot formation. Its effectiveness is commonly monitored using a laboratory value called the International Normalized Ratio, or INR. Levothyroxine can enhance the effects of warfarin. The mechanism involves increased metabolism and breakdown of vitamin K-dependent clotting factors. As thyroid hormone activity increases, these clotting proteins are cleared more rapidly from the circulation. This means that warfarin may produce a stronger anticoagulant effect than expected. As a result, the INR may rise, indicating a greater tendency toward bleeding. If this interaction is not recognized, patients may face an increased risk of bruising, bleeding, or excessive anticoagulation. For this reason, careful monitoring is essential whenever levothyroxine is started, discontinued, or significantly adjusted in a patient receiving warfarin therapy. In summary, estrogens can increase thyroxine-binding globulin levels and raise thyroid hormone requirements, while androgens can decrease thyroxine-binding globulin and alter hormone availability. Levothyroxine can also potentiate the effects of warfarin by accelerating the breakdown of clotting factors, leading to an increase in INR and a potentially greater risk of bleeding. Understanding these interactions is essential for safe and effective thyroid hormone management. Pregnancy is one of the most important special situations in thyroid hormone management. For patients taking levothyroxine, pregnancy often changes thyroid hormone requirements almost immediately. The reason is simple. During pregnancy, the body must provide thyroid hormone not only for the mother, but also for the developing fetus. In the early stages of pregnancy, the fetal thyroid gland is not fully functional. As a result, the fetus depends heavily on maternal thyroxine, or T4, for normal growth and development. This is especially important for brain and nervous system development. Adequate maternal thyroid hormone levels support healthy fetal neurological maturation during the critical first trimester and beyond. At the same time, Pregnancy causes major hormonal changes within the mother's body. One of the most significant changes is a marked increase in estrogen levels. Higher estrogen concentrations stimulate the liver to produce more thyroxine-binding globulin, or TBG. As thyroxine-binding globulin levels rise, a larger portion of circulating thyroid hormone becomes protein-bound. This reduces the amount of free hormone available for immediate biological activity. To compensate for these changes, the body requires additional thyroid hormone. For patients with normal thyroid function, the thyroid gland can usually increase hormone production naturally. However, patients with hypothyroidism who rely on levothyroxine cannot make this adjustment on their own. Therefore, their medication dose often needs to be increased. In many cases, the required increase is approximately 25 to 50% above the pre-pregnancy dose. The exact adjustment varies from patient to patient, but increased thyroid hormone requirements are extremely common during pregnancy. Timing is crucial. Because fetal development begins very early, waiting weeks for laboratory confirmation of changing thyroid requirements may result in inadequate hormone availability during a critical developmental period. For this reason, clinical guidelines commonly recommend an immediate increase in levothyroxine dosage as soon as pregnancy is confirmed by a positive pregnancy test. This proactive approach helps ensure that thyroid hormone levels remain adequate while follow-up laboratory monitoring is arranged. Regular thyroid function testing throughout pregnancy is also essential. Thyroid-stimulating hormone and thyroid hormone levels are monitored closely so that further dose adjustments can be made when necessary. The goal is to maintain optimal thyroid hormone availability for both mother and baby throughout pregnancy. In summary, pregnancy significantly increases the body's demand for thyroid hormone because of rising estrogen levels, increased thyroxine-binding globulin production, and the developing fetus's dependence on maternal T4. As a result, many patients require a 25 to 50% increase in levothyroxine dosage. For those already receiving thyroid hormone replacement, dose adjustment should occur promptly after a positive pregnancy test, followed by careful monitoring throughout pregnancy. Not all patients with hypothyroidism are managed in the same way. Certain populations require special consideration because they are more vulnerable to the effects of thyroid hormone therapy. One important group is elderly patients, particularly those with underlying cardiovascular disease. In younger and otherwise healthy individuals, standard replacement doses may be started relatively quickly. However, this approach can be risky in older adults. The reason lies in the effects of thyroid hormone on the heart. Thyroid hormones increase heart rate, enhance cardiac contractility, and raise the body's overall metabolic demand. While these effects are beneficial when correcting hypothyroidism, they can place additional stress on an aging or diseased cardiovascular system. If thyroid hormone is introduced too aggressively, patients may develop chest pain, worsening angina, palpitations, or cardiac arrhythmias. To minimize these risks, clinicians follow a low and slow approach. Treatment is typically initiated with a very small levothyroxine dose, often between 12.5 and 25 micrograms daily. The dose is then increased gradually over time based on clinical response and laboratory monitoring. This cautious strategy allows the cardiovascular system to adapt safely to increasing thyroid hormone levels. At the opposite end of the spectrum is one of the most severe endocrine emergencies, myxedema coma. Despite its name, patients are not always unconscious. However, the condition represents extreme, life-threatening hypothyroidism and requires immediate medical intervention. Patients may present with profound lethargy, hypothermia, respiratory depression, low blood pressure, altered mental status, and severe metabolic dysfunction. Without rapid treatment, mortality rates can be very high. Because these patients are critically ill, oral medications may not be absorbed reliably. For this reason, intravenous levothyroxine, or IVLT4, is the preferred treatment. Intravenous administration ensures rapid and predictable delivery of thyroid hormone directly into the circulation. However, thyroid hormone replacement is only part of the treatment strategy. Patients with myxedema coma may also have unrecognized adrenal insufficiency. If thyroid hormone is administered without addressing this possibility, the patient may experience cardiovascular collapse or worsening adrenal crisis. To prevent this complication, intravenous corticosteroids are administered alongside thyroid hormone therapy. Hydrocortisone is the most commonly used corticosteroid in this setting. The corticosteroid is typically started immediately and continued until adrenal insufficiency has been excluded or adequately treated. In summary, elderly patients and those with cardiac disease require cautious, low and slow, levothyroxine dosing, usually beginning with 12.5 to 25 micrograms daily. In contrast, myxedema coma is a life-threatening endocrine emergency that requires prompt treatment with intravenous levothyroxine and intravenous hydrocortisone to stabilize the patient and improve survival outcomes. Let's apply what we've learned to a real-world clinical scenario. Imagine a 35-year-old woman who visits her healthcare provider because she has been feeling unwell for several months. She reports gradual weight gain despite no major changes in her diet or activity level. She also complains of cold intolerance. While others feel comfortable, she often feels unusually cold and needs extra layers of clothing. These symptoms may seem nonspecific at first, but together they raise suspicion for hypothyroidism. As the thyroid gland slows down, the body's metabolism decreases. This can lead to weight gain, fatigue, cold sensitivity, dry skin, constipation, and reduced energy levels. To investigate further, thyroid function tests are ordered. The results reveal a thyroid-stimulating hormone, or TSH, level of 14.5 million international units per liter. This value is significantly elevated above the normal reference range. An elevated thyroid-stimulating hormone suggests that the pituitary gland is working harder than normal to stimulate the thyroid gland. Next, the free thyroxine level is reviewed. The patient's free thyroxine is 0.6, which is below the normal range. This finding confirms that the thyroid gland is not producing enough thyroid hormone to meet the body's needs. At this point, the combination of a high thyroid-stimulating hormone and a low free thyroxine strongly indicates overt primary hypothyroidism. But the evaluation does not stop there. Additional testing reveals positive antithyroid peroxidase antibodies, commonly called antithyroid peroxidase antibodies. These antibodies are important because they provide evidence of an autoimmune process. In this condition, the immune system mistakenly attacks thyroid tissue, leading to chronic inflammation and gradual destruction of the gland. This autoimmune disorder is known as Hashimoto's thyroiditis. Hashimoto's thyroiditis is the most common cause of hypothyroidism in many parts of the world. Over time, the damaged thyroid gland loses its ability to produce sufficient thyroid hormone, resulting in the symptoms and laboratory abnormalities seen in this patient. When all the findings are considered together, the diagnosis becomes clear. The patient has overt primary hypothyroidism caused by Hashimoto's thyroiditis. The elevated thyroid-stimulating hormone shows that the pituitary gland is trying to stimulate the thyroid. The low free thyroxine confirms inadequate hormone production. The positive anti-thyroid peroxidase antibodies identify the underlying autoimmune cause. This case demonstrates the classic presentation of Hashimoto's disease and highlights how symptoms, thyroid function tests, and antibody testing work together to establish a definitive diagnosis of overt primary hypothyroidism. Now that the diagnosis has been established, the next step is treatment. Our 35-year-old patient has overt primary hypothyroidism caused by Hashimoto's thyroiditis. Because her thyroid gland is no longer producing enough hormone, replacement therapy is required. The standard treatment is levothyroxine, also known as LT4. Levothyroxine replaces the hormone that the thyroid can no longer produce in adequate amounts. Once absorbed, it is converted into the active hormone triiodothyronine, helping restore normal metabolic function throughout the body. For most healthy adults with overt hypothyroidism, the typical starting dose is approximately 1.6 micrograms per kilogram of body weight per day. This weight-based approach helps estimate the amount of hormone needed to replace normal thyroid function. The goal is to restore thyroid hormone levels to the normal range and relieve symptoms such as fatigue, weight gain, cold intolerance, and reduced energy. However, prescribing the medication is only part of successful treatment. Patient education is equally important. One of the first topics to discuss is proper medication administration. Levothyroxine is absorbed best when taken on an empty stomach. Patients are typically advised to take the medication first thing in the morning with water and avoid eating for at least 30 to 60 minutes afterward. This timing helps maximize absorption and promotes more consistent hormone levels. Consistency is key. Taking the medication at the same time each day helps reduce fluctuations and improves treatment effectiveness. Patients should also understand that improvement will not happen overnight. Because levothyroxine has a long half-life and works by gradually restoring hormone balance, symptom relief develops over time. Some patients begin to feel better within 1 to 2 weeks, but the full therapeutic effect often requires several weeks. This is why immediate dose adjustments are usually avoided. After starting treatment, the body needs time to reach a new steady state. For this reason, follow-up laboratory testing is generally scheduled 4 to 6 weeks after initiating therapy. Checking thyroid function too early may not accurately reflect the medication's full effect. At the follow-up visit, thyroid-stimulating hormone and, when appropriate, free thyroxine levels are reviewed to determine whether the dose is adequate or requires adjustment. The patient should also be reassured that dose refinement is a normal part of treatment. Many individuals require 1 or more adjustments before the optimal dose is found. In summary, management of overt hypothyroidism typically begins with levothyroxine at approximately 1.6 micrograms per kilogram per day. Patients should be instructed to take the medication on an empty stomach and to maintain consistent dosing habits. Follow-up thyroid function testing is usually performed after 4 to 6 weeks, allowing enough time for hormone levels to stabilize and treatment effectiveness to be properly assessed. Let's look at another common clinical scenario that highlights the importance of medication interactions. Imagine a patient with hypothyroidism who has been doing well for years. For the past 5 years, their thyroid hormone levels have remained stable. Their symptoms have been well controlled, and routine blood tests have consistently shown good treatment response. Suddenly, things begin to change. The patient starts feeling tired again. Energy levels decline. They may notice increased sensitivity to cold, mild weight gain, or difficulty concentrating. These symptoms sound familiar because they resemble the original signs of hypothyroidism. When laboratory tests are repeated, the results reveal an elevated thyroid-stimulating hormone level. A rising thyroid-stimulating hormone is an important clue. It suggests that the body is no longer receiving enough effective thyroid hormone, even though the patient has continued taking the same levothyroxine dose. At first glance, this situation may seem confusing. If the medication dose has not changed, why are symptoms returning? This is where a careful medication history becomes extremely important. Further questioning reveals that the patient recently started taking iron and calcium supplements. This detail may seem minor, but it can completely explain the problem. Both iron and calcium are well-known causes of levothyroxine absorption interference. When these minerals are present in the digestive tract at the same time as levothyroxine, they can bind directly to the medication. This process is known as chelation. The resulting complex becomes difficult for the intestine to absorb. As a result, less levothyroxine reaches the bloodstream. Even though the patient is swallowing the same dose every day, the body is actually receiving less usable thyroid hormone. Over time, thyroid hormone levels begin to fall. The pituitary gland senses this decline and responds by increasing thyroid-stimulating hormone production. Eventually, hypothyroid symptoms start to reappear. This case demonstrates an important principle in thyroid management. When a previously stable patient develops worsening thyroid control, the first step is not always increasing the dose. Instead, clinicians should investigate potential causes of reduced absorption, medication interactions, or changes in daily routine. Many cases can be corrected simply by adjusting medication timing. Patients are often advised to take levothyroxine on an empty stomach and separate iron or calcium supplements by several hours. This allows the thyroid medication to be absorbed properly before the minerals enter the digestive tract. In summary, a patient who has remained stable on levothyroxine for years may develop recurrent hypothyroid symptoms and an elevated thyroid-stimulating hormone after starting iron or calcium supplements. These minerals can bind to levothyroxine in the gastrointestinal tract, reducing absorption and lowering the amount of thyroid hormone reaching the bloodstream. A careful medication history is often the key to identifying and correcting the problem. Now let's see how this case was successfully resolved. The patient had been stable on levothyroxine for many years. Symptoms were well controlled, and thyroid function tests had remained within the target range. Then, seemingly out of nowhere, hypothyroid symptoms returned. Laboratory testing revealed an elevated thyroid-stimulating hormone level, suggesting that the body was no longer receiving enough effective thyroid hormone. A careful review of the patient's history uncovered the likely cause. The patient had recently started taking iron and calcium supplements. These supplements were not harmful by themselves, but they were being taken too close to the levothyroxine dose. As we discussed earlier, both iron and calcium can bind to levothyroxine in the digestive tract. When this happens, the medication forms complexes that are difficult for the intestine to absorb. The problem was not the prescribed dose. The problem was that less of the medication was actually reaching the bloodstream. This distinction is important. Many clinicians might be tempted to immediately increase the levothyroxine dose when they see a rising thyroid-stimulating hormone. However, before changing the prescription, it is essential to identify and correct any factors affecting absorption. In this case, the solution was surprisingly simple. The patient was instructed to separate levothyroxine from iron and calcium supplements by at least 4 hours. This timing adjustment allows levothyroxine to be absorbed before the minerals enter the digestive tract and interfere with the process. The patient continued taking the same levothyroxine dose. No increase in medication was required. After several weeks, follow-up thyroid function testing was performed. The results showed a gradual return of thyroid-stimulating hormone toward the normal range. As absorption improved, more thyroid hormone entered the bloodstream and became available to the body's tissues. The patient's symptoms also began to improve. Energy levels increased, fatigue lessened. The signs of inadequate thyroid hormone replacement gradually resolved. This outcome highlights a valuable clinical lesson. Not every abnormal laboratory result requires a higher medication dose. Sometimes the issue is not how much medication is prescribed, but how much medication is actually absorbed. A thorough review of supplements, medications, dietary habits, and dosing schedules can often reveal the true cause of treatment failure. In summary, the key intervention in this case was separating levothyroxine from iron and calcium supplements by at least 4 hours. This simple adjustment restored proper absorption of the medication. As a result, thyroid-stimulating hormone levels normalized, symptoms improved, and effective thyroid hormone replacement was achieved without any change to the prescribed levothyroxine dose. Let's explore another important clinical case. This scenario highlights why thyroid hormone replacement is not always as simple as prescribing a standard dose. Imagine a 78-year-old man who has just been diagnosed with hypothyroidism. He reports symptoms such as fatigue, reduced energy, cold intolerance, and slowing of daily activities. Laboratory testing confirms that his thyroid hormone levels are low and that treatment is needed. However, there is an important complication. The patient has a history of myocardial infarction, commonly known as a heart attack. This detail immediately changes the treatment approach. In a younger, healthy patient, clinicians might start a full replacement dose of levothyroxine. But in this case, the decision requires much greater caution. Why? Because thyroid hormone has powerful effects on the cardiovascular system. As thyroid hormone levels increase, the body's metabolic rate begins to rise. Cells consume more oxygen, energy production increases, organ systems become more active. The heart is no exception. Thyroid hormone increases heart rate, strengthens the force of cardiac contractions, and raises the overall workload of the heart. For most patients, these effects help restore normal physiological function. However, in someone with a history of heart disease, they can create potential risks. This is where the clinical dilemma emerges. On one hand, hypothyroidism should be treated. Restoring normal thyroid hormone levels can improve energy, cognitive function, metabolism, and overall quality of life. On the other hand, correcting hypothyroidism too quickly may place excessive stress on a vulnerable heart. A sudden increase in metabolic demand can increase myocardial oxygen requirements. In susceptible patients, this may trigger chest pain, worsening angina, abnormal heart rhythms, or even additional cardiovascular complications. The challenge is finding the right balance. Clinicians must carefully restore thyroid hormone levels while minimizing cardiovascular risk. This is why treatment in elderly patients with cardiac disease is often described as a low and slow process. Rather than rapidly correcting the hormone deficiency, therapy is introduced gradually and monitored closely. Small dose adjustments allow the heart and circulatory system time to adapt safely to changing metabolic demands. Regular follow-up visits and thyroid function tests help guide this process. The goal is not simply to normalize laboratory values. The goal is to improve thyroid function while protecting the patient's cardiovascular health. In summary, this case illustrates a common therapeutic challenge. A 78-year-old man with newly diagnosed hypothyroidism and a history of myocardial infarction needs thyroid hormone replacement, but treatment must be approached carefully. The central dilemma is balancing the benefits of restoring normal metabolism against the potential cardiac risks associated with increasing thyroid hormone levels too rapidly. This is why cautious, individualized therapy is essential in elderly patients with cardiovascular disease. Now let's see how our 78-year-old patient with a history of myocardial infarction is managed safely. The diagnosis of hypothyroidism has been confirmed, and treatment is necessary. However, because of the patient's age and underlying heart disease, the usual full replacement strategy would not be appropriate. Instead, clinicians use what is commonly called the low and slow approach. The principle is simple. Start with a very small dose of levothyroxine and increase it gradually over time. This method allows the cardiovascular system to adapt safely as thyroid hormone levels begin to rise. In this case, treatment is initiated with levothyroxine at just 12.5 micrograms daily. For comparison, this is substantially lower than the starting dose often used in younger, healthy adults. The goal is not rapid correction. The goal is safe correction. Remember, thyroid hormone increases metabolic activity throughout the body. As metabolism rises, the heart must work harder. Heart rate may increase. Cardiac output may rise. Oxygen demand within the heart muscle can also increase. For a patient with a history of coronary artery disease or a previous heart attack, these changes must occur gradually. A sudden increase in thyroid hormone exposure could provoke chest pain, worsen angina, or trigger abnormal heart rhythms. That is why patience becomes an essential part of treatment. After starting therapy, the patient is monitored closely. Follow-up visits focus on two key areas. The first is thyroid function testing. Thyroid-stimulating hormone levels help determine whether thyroid hormone replacement is moving in the right direction. The second is cardiovascular assessment. Clinicians carefully watch for symptoms such as palpitations, chest discomfort, shortness of breath, worsening angina, or signs of cardiac stress. If the patient remains stable and no concerning cardiac symptoms develop, the dose can be increased gradually. A common strategy is to increase levothyroxine by 12.5 micrograms at a time. These adjustments are typically made every 6 weeks. The 6-week interval is important because levothyroxine has a long half-life and requires several weeks to reach a new steady state after each dose change. Increasing the dose too quickly could make it difficult to accurately assess the patient's response and could increase cardiovascular risk. Over time, this stepwise approach allows thyroid hormone levels to improve while minimizing stress on the heart. The process may take several months, but safety remains the priority. In summary, elderly patients with significant cardiac disease are often treated using low and slow strategy. Therapy may begin with levothyroxine at 12.5 micrograms daily, followed by gradual increases of 12.5 micrograms every 6 weeks. Dose adjustments are guided by both thyroid-stimulating hormone levels and cardiac symptoms, ensuring that hypothyroidism is corrected safely while protecting cardiovascular health. As we conclude our discussion on thyroid hormone replacement therapy, let's review the two main pharmacological agents used in the management of hypothyroidism. Although both medications are forms of thyroid hormone, they differ significantly in how they work, how long they remain in the body, and how they are used in clinical practice. Let's start with levothyroxine, also known as LT4. Levothyroxine is considered a prohormone. This means that after administration, it must be converted by the body's diadenous enzymes into liothyronine, or T3, the active thyroid hormone. Because the body regulates this conversion naturally, levothyroxine provides a physiologic and controlled approach to thyroid hormone replacement. One of its greatest advantages is stability. Levothyroxine has a long half-life of approximately 7 days. As a result, blood hormone levels remain relatively consistent throughout the day. This stable pharmacokinetic profile allows for convenient once-daily dosing and reduces the likelihood of large fluctuations in thyroid hormone concentrations. The long half-life also provides a buffering effect against occasional missed doses. For these reasons, levothyroxine is considered the standard of care and remains the first-line treatment for most patients with hypothyroidism worldwide. Now let's turn to liothyronine, or LT3. Unlike levothyroxine, liothyronine is already the active thyroid hormone. It does not require conversion before exerting its biological effects. Once absorbed, it can directly enter cells, bind thyroid hormone receptors, and influence gene transcription. Because of this direct activity, liothyronine acts more rapidly than levothyroxine. It is also considerably more potent on a microgram to microgram basis. However, this increased potency comes with important challenges. Liothyronine has a much shorter half-life, averaging approximately 1 day. As a result, blood concentrations rise quickly after each dose and decline relatively rapidly afterward. This can create peaks and troughs in hormone levels throughout the day. To minimize these fluctuations, liothyronine often requires multiple daily doses rather than a single daily administration. The shorter half-life and greater potency can also increase the risk of symptoms related to excessive thyroid hormone exposure, particularly in sensitive individuals. When comparing these two medications, an important pattern emerges. Levothyroxine provides gradual, stable, and predictable thyroid hormone replacement. Liothyronine provides faster and more potent thyroid hormone activity, but requires closer monitoring and more frequent dosing. In summary, levothyroxine is a prohormone with a long 7-day half-life, excellent stability, and a well-established role as standard therapy. Liothyronine is the active thyroid hormone, more potent, faster acting, and characterized by a short 1-day half-life that often necessitates multiple daily doses. Understanding these differences helps clinicians select the most appropriate therapy for each individual patient. As we wrap up our discussion on thyroid hormone replacement therapy, let's review some of the most important clinical pearls every healthcare professional should remember. These practical lessons can help improve treatment outcomes and prevent common management mistakes. First, remember that patience is essential when monitoring levothyroxine therapy. Levothyroxine has a long half-life of about 7 days. Because of this, the body needs time to reach a new steady state after starting treatment or changing the dose. This is why thyroid-stimulating hormone should generally be checked about 4 to 6 weeks after a dose adjustment. Testing too early can lead to misleading results and unnecessary changes in therapy. Another key point involves medication administration. Levothyroxine works best when taken on an empty stomach. Food can interfere with absorption and reduce the amount of medication reaching the bloodstream. For optimal absorption, patients are typically advised to take levothyroxine with water and wait at least 30 to 60 minutes before eating. Consistency is just as important as the dose itself. Pregnancy deserves special attention. As soon as pregnancy occurs, thyroid hormone requirements often increase significantly. Higher estrogen levels increase thyroxine-binding globulin, and the developing fetus depends on maternal thyroid hormone, especially during early pregnancy. Because of these increased demands, prompt dose adjustment is often necessary. Waiting until symptoms develop or delaying treatment changes can result in inadequate thyroid hormone availability during a critical stage of fetal development. Another important pearl applies to elderly patients and those with cardiovascular disease. In these individuals, thyroid hormone replacement should not be rushed. Thyroid hormones increase heart rate and metabolic demand, which can place stress on a vulnerable cardiovascular system. This is why clinicians follow the low and slow approach. Starting with a small dose and increasing gradually helps reduce the risk of angina, arrhythmias, and other cardiac complications. Finally, always remember the interaction between levothyroxine and warfarin. As thyroid hormone levels increase, the body breaks down vitamin K-dependent clotting factors more rapidly. This can enhance the anticoagulant effect of warfarin and cause the international normalized ratio, or INR, to rise. If this interaction is overlooked, the risk of bleeding may increase. For this reason, patients receiving both medications require careful monitoring whenever thyroid hormone therapy is started, stopped, or adjusted. In summary, successful thyroid hormone management depends on more than simply prescribing a medication. Check thyroid stimulating hormone at 4 to 6 weeks after dose changes. Take levothyroxine on an empty stomach. Act promptly when pregnancy occurs. Use a low and slow strategy in elderly or cardiac patients. And always monitor warfarin-treated patients carefully. These simple clinical pearls can make a significant difference in safe and effective thyroid hormone replacement therapy. Let's test our understanding with a quick multiple-choice question. Here's the scenario. Which of the following best describes the cellular mechanism of action of levothyroxine? Option A. Activation of a membrane-bound G-protein-coupled receptor, or GPCR. Option B. Binding to a nuclear receptor and regulation of gene transcription. Option C. Inhibition of thyroid peroxidase, also known as TPO. Option D. Stimulation of the sodium iodide symporter, or NIS. Take a moment and think about your answer. The correct answer is option B. Binding to a nuclear receptor and regulation of gene transcription. Let's see why. Levothyroxine, or LT4, is a synthetic form of thyroxine. After entering the body, much of it is converted into triiodothyronine, the active thyroid hormone. Triiodothyronine then enters target cells and travels to the nucleus. Inside the nucleus, it binds to thyroid hormone receptors known as TR-alpha and TR-beta. These receptors function as transcription factors. After binding, the hormone receptor complex interacts with specific regions of DNA called thyroid hormone response elements, or TREs. This process alters gene transcription and ultimately changes the production of proteins that regulate metabolism, growth, development, and energy utilization. In other words, thyroid hormones work primarily by influencing which genes are turned on or off inside the cell. Now let's quickly eliminate the other options. Option A is incorrect because levothyroxine does not primarily exert its effects through membrane-bound G-protein-coupled receptors. While some rapid non-genomic thyroid hormone actions have been described, the major therapeutic effects occur through nuclear receptor-mediated gene regulation. Option C is also incorrect. Thyroid peroxidase inhibition is the mechanism of action of antithyroid medications such as methimazole and propylthiouracil. These drugs reduce thyroid hormone synthesis, whereas levothyroxine replaces thyroid hormone. Option D is incorrect as well. The sodium iodide symporter is involved in transporting iodide into thyroid cells during hormone production. Levothyroxine does not stimulate this transporter as its primary mechanism of action. The key takeaway is simple. Levothyroxine ultimately works through a genomic mechanism. After conversion to triiodothyronine, it binds nuclear thyroid hormone receptors and regulates gene transcription. This explains why the drug's effects develop gradually over days to weeks rather than immediately after administration. So if you selected option B, you're absolutely correct. Levothyroxine's primary cellular mechanism is nuclear receptor activation, leading to changes in gene transcription and protein synthesis throughout the body. Let's test another important clinical concept with a quick multiple-choice question. Here's the scenario. A patient with hypothyroidism has been stable on levothyroxine for several years. Their symptoms have been well controlled, and previous thyroid function tests have been within the target range. However, at a recent follow-up visit, the patient reports increasing fatigue and mild weight gain. Laboratory testing reveals an elevated thyroid-stimulating hormone level. The question is this: which over-the-counter medication is most likely responsible for this change? Option A, vitamin C. Option B, acetaminophen. Option C, calcium carbonate. Option D, diphenhydramine. Take a moment and think about your answer. The correct answer is option C, calcium carbonate. Let's explore why. Calcium carbonate is a common ingredient in calcium supplements and many antacid products. Although it is widely used and generally safe, it can significantly interfere with levothyroxine absorption. When calcium carbonate and levothyroxine are present in the gastrointestinal tract at the same time, they can bind together. This process is known as chelation. Once this complex forms, the intestine has difficulty absorbing the thyroid medication. As a result, less levothyroxine reaches the bloodstream. Even though the patient continues taking the same prescribed dose, the body effectively receives less thyroid hormone. Over time, thyroid hormone levels may decline. The pituitary gland senses this reduction and responds by producing more thyroid-stimulating hormone, or TSH. The result is an elevated thyroid-stimulating hormone level and, in some cases, the return of hypothyroid symptoms. Now let's briefly review the other options. Vitamin C is not a common cause of elevated thyroid-stimulating hormone in patients taking levothyroxine. In some situations, it may even improve absorption in patients with certain gastrointestinal conditions. Acetaminophen does not significantly interfere with levothyroxine absorption or thyroid hormone replacement therapy. Diphenhydramine, an antihistamine commonly used for allergies and sleep aid purposes, is also not a typical cause of impaired levothyroxine absorption. This question highlights an important clinical pearl. When a previously stable hypothyroid patient develops an elevated thyroid-stimulating hormone, clinicians should not immediately assume that the disease is worsening. A careful review of medications, supplements, and daily routines is often the key to finding the answer. Many cases result from absorption interference rather than inadequate dosing. The solution may be as simple as adjusting medication timing. Patients are usually advised to separate levothyroxine from calcium supplements by at least 4 hours. This allows proper absorption and helps maintain stable thyroid hormone levels. So if you selected option C, calcium carbonate, you got it right. It's one of the most common over-the-counter causes of reduced levothyroxine absorption and an elevated thyroid-stimulating hormone in otherwise stable patients. Let's finish with another high-yield clinical question. This one focuses on pregnancy, one of the most important special populations in thyroid hormone management. Here's the scenario. A patient with hypothyroidism is doing well on levothyroxine therapy. She recently takes a home pregnancy test, and the result is positive. What should happen next? Option A. Keep the levothyroxine dose the same. Option B. Decrease the dose. Option C. Increase the dose by 25 to 50%. Option D. Switch to liothyronine, or LT3. Take a moment and think about your answer. The correct answer is option C. Increase the dose by 25 to 50%. Let's discuss why. Pregnancy creates a significant increase in thyroid hormone requirements almost from the very beginning. As pregnancy progresses, estrogen levels rise substantially. Higher estrogen stimulates the liver to produce more thyroxine-binding globulin, or TBG. As thyroxine-binding globulin levels increase, more thyroid hormone becomes bound to proteins in the bloodstream. This reduces the amount of free hormone available to tissues. At the same time, the developing fetus depends heavily on maternal thyroid hormone, especially during the first trimester. Early in pregnancy, the fetal thyroid gland is not yet fully functional. As a result, the fetus relies on maternal thyroxine to support normal growth and brain development. These combined factors increase the mother's thyroid hormone needs. Patients with healthy thyroid glands can usually respond by producing more hormone naturally. However, patients with hypothyroidism depend on levothyroxine replacement and cannot make this adjustment on their own. That is why an increase in levothyroxine dosage is often required as soon as pregnancy is confirmed. Waiting for symptoms to appear is not recommended. Waiting several weeks for routine follow-up may also delay important treatment adjustments during a critical period of fetal development. Now let's review the incorrect options. Option A. Keeping the dose unchanged may lead to inadequate thyroid hormone availability during pregnancy. Option B. Decreasing the dose would move in the wrong direction because thyroid hormone requirements typically increase, not decrease. Option D. Switching to liothyronine is also inappropriate. Levothyroxine remains the preferred thyroid hormone replacement during pregnancy because it provides thyroxine, which is essential for both maternal physiology and fetal development. The key clinical message is simple. A positive pregnancy test should immediately trigger consideration of increased thyroid hormone requirements in patients receiving levothyroxine. Early dose adjustment and close monitoring can help maintain adequate thyroid hormone levels throughout pregnancy. So if you selected option C, increase the levothyroxine dose by approximately 25 to 50%, you chose the correct answer. This is one of the most important clinical interventions in the management of hypothyroidism during pregnancy. Let's tackle another high-yield clinical question. This one focuses on a topic that often appears in exams and everyday clinical practice: thyroid hormone monitoring. Here's the question. A patient with hypothyroidism has recently had their levothyroxine dose adjusted. How soon should the thyroid-stimulating hormone level be checked? Option A. 3 to 5 days. Option B. 1 week. Option C. 4 to 6 weeks. Take a moment and think about your answer. The correct answer is option C. 4 to 6 weeks. Let's explore the reasoning behind this important recommendation. At first glance, it might seem reasonable to check thyroid-stimulating hormone within a few days of changing the dose. After all, if the medication has been adjusted, wouldn't we want to know immediately whether it is working? The problem is that levothyroxine does not act that quickly. One of the defining pharmacokinetic features of levothyroxine is its long half-life. On average, levothyroxine remains in the body for approximately 7 days before half of the drug is eliminated. Because of this long half-life, hormone levels change gradually rather than rapidly. Each new dose contributes to a slowly growing pool of thyroid hormone within the body. This means that a new equilibrium is not reached immediately after a dose adjustment. Instead, the body requires several weeks to fully adapt to the change. This process is known as reaching a steady state. A steady state occurs when the amount of medication entering the body equals the amount being removed. Only after this balance is achieved can laboratory tests accurately reflect the full impact of the new dose. For levothyroxine, reaching this steady state typically requires 4 to 6 weeks. That is why clinicians generally wait this amount of time before repeating thyroid-stimulating hormone measurements. Now let's examine the incorrect answers. Option A, checking thyroid-stimulating hormone after 3 to 5 days, is far too early. The body has not yet had enough time to stabilize thyroid hormone levels or produce a reliable thyroid-stimulating hormone response. Option B, checking after 1 week, is also premature. Although some hormone changes may be occurring, the full physiological effect of the dose adjustment has not yet developed. Testing too early can lead to misleading results and unnecessary dose changes. This is a common clinical pitfall. Patience is often one of the most important parts of successful thyroid hormone management. The key takeaway is simple. Levothyroxine works gradually because of its long half-life and slow attainment of steady state. For this reason, thyroid-stimulating hormone should generally be reassessed 4 to 6 weeks after starting therapy or after any dose adjustment. So if you selected option C, 4 to 6 weeks, you chose the correct answer. It's the optimal time frame for accurately evaluating the effect of a levothyroxine dose change and making informed treatment decisions. Let's finish with another high-yield clinical question. This one focuses on an important drug interaction that every healthcare professional should know. Here's the question. What is the interaction between levothyroxine, or LT4, and warfarin? Option A, decreased levothyroxine absorption. Option B, increased clotting factor catabolism and an increased INR. Option C, CYP enzyme induction. Option D, no interaction. Take a moment and choose your answer. The correct answer is option B, increased clotting factor catabolism and an increased INR. Let's break it down. Warfarin is an anticoagulant medication that helps prevent harmful blood clots. Its effectiveness is commonly monitored using a laboratory test called the International Normalized Ratio, or INR. A higher INR generally indicates a greater anticoagulant effect and a higher tendency toward bleeding. When levothyroxine therapy is initiated or increased, thyroid hormone activity throughout the body also increases. One consequence of this increased metabolic activity is a faster breakdown of vitamin K-dependent clotting factors. These clotting factors are essential components of the blood coagulation system. As thyroid hormone accelerates their catabolism, fewer clotting factors remain available in circulation. This enhances the anticoagulant effect of warfarin. In practical terms, warfarin becomes more potent. As a result, the patient's INR may rise above the desired therapeutic range. If this interaction is not recognized, the risk of excessive anticoagulation increases. Patients may develop easy bruising, nosebleeds, bleeding gums, prolonged bleeding from minor injuries, or, in severe cases, more serious hemorrhagic complications. This is why careful monitoring is essential whenever levothyroxine therapy is started, stopped, or significantly adjusted in a patient receiving warfarin. Now let's review the incorrect answers. Option A is incorrect because the major interaction is not decreased levothyroxine absorption. Although levothyroxine absorption can be affected by certain supplements and medications, warfarin is not known for causing this particular problem. Option C is also incorrect. This interaction is not primarily due to induction of cytochrome P450 enzymes. Instead, it results from increased metabolic turnover of clotting factors caused by enhanced thyroid hormone activity. Option D is clearly incorrect because a clinically significant interaction does exist between these two medications. The key clinical pearl is simple. When thyroid hormone levels increase, the anticoagulant effect of warfarin may become stronger. For this reason, INR should be monitored carefully whenever levothyroxine therapy is initiated or adjusted. So if you selected option B, you're absolutely correct. Levothyroxine can potentiate the effects of warfarin by increasing clotting factor catabolism, leading to an elevated INR and a potentially increased risk of bleeding if monitoring is not performed appropriately. This presentation is based on standard pharmacology texts and currently accepted clinical practice guidelines. Thank you for your attention.